And my name is Winnie Ogejo, and I work at the Institute of Economic Affairs. The Institute of Economic Affairs is a public policy think tank. We are based in Nairobi, Kenya, and what we do is we conduct research and use our research findings to have policy conversations that are geared towards giving the economic policy direction. So how we operate at the Institute is we work across 6 programs. So we have the Constitution, Law and Economics program. We have the Popular Economics program. We have the Public Finance Management program. We have the International Trade program. We have the Economic Competition and Regulation program. And of course, we have yours truly, the conveners of today's meeting, the Futures and Foresights program. So that is who we are for those who are joining us for the first time. And before we go into our conversation, just a few housekeeping. We have one speaker who we will be engaging this morning to have the conversation we intend to have. And so all of us, we will be kindly requesting that we keep ourselves on mute and keep our cameras off as the conversation is going. And then during the plenary and the Q&A session, you will have an opportunity to ask your question to the speaker. But in the meantime, as we will be making as the speaker will be speaking to us, if you have any question that you think you need to quickly type in, kindly please feel free to use the chat box that on the chat at the top of your toolbar. And we will look at those questions during plenary, and we will have an opportunity to respond. And also we'll be giving you an opportunity during the plenary to unmute yourselves and just have a conversation with us. So kindly let's adhere to those rules as we are joining into the meeting. So as I mentioned this morning, we want to have a conversation on the Social Health Insurance Fund and whether or not it's amiss. There's ongoing conversation about it, and people have different views on whether or not we are getting it right with that particular policy reform. So our business at the Institute is to have this policy conversation so that moving forward, even as you engage and try to better understand what is going on with the health sector, we are having those conversations from a point of knowledge. So we are privileged this morning to have Dr. Brian Lishenga, who is the chairman for the Rural and Urban Private Hospitals Association, who will be speaking to us about the Social Health Insurance Fund and whether or not it's a myth. A quick overview. So we all know that we have been transitioning from the National Health Insurance Fund to what we are calling the Social Health Insurance Fund. So this Social Health Insurance Fund is a component that is being managed under the Social Health Authority. So SHA is managing 3 funds. We have the Social Health Insurance Fund, we have the Emergency, Chronic, and Critical Illness Fund, and then we have the Primary Healthcare Fund. So for the Primary Healthcare Fund and the Emergency, Chronic, and Critical Illness Fund, those are being funded by the Exchequer. They're being budgeted for and being funded by the Exchequer. And then, of course, we come in under the Social Health Insurance Fund, where as Kenyans, we are expected to make a contribution towards that fund, that then allows us to access healthcare. So the whole point for moving from NHIF to SHIF was for us to accelerate our attainment of universal health coverage. And remember, universal health coverage is pillared by 3 things: improved access, improved accessibility, and equity. So the narrative behind SHIF is it's actually enforcing and ensuring that we actually achieve access to health. We are actually in a position where we are saying healthcare in Kenya is affordable, and we are also in a position where we are saying there is equity in how we are accessing health. So there is no equity gap in how we are receiving healthcare services in Kenya. But given the happenings that we have seen and the conversations that are ongoing, of course, there is a query and there are questions being raised around, are we really working towards ensuring equity, affordability, and access? Because in the recent past, we have seen patients being turned back from private hospitals, for instance. They cannot be able to use their health schemes under SHIF. And so it poses a challenge. Are we widening the equity gap in healthcare service delivery, or are we reducing it? And it's obvious that there's a widening of that gap. And then, of course, there's the questions of affordability where the burden seems to be lying more on those who are earning more. And so the question then begs, because with the registration, we have seen about 21 million Kenyans have so far registered, but out of the 21 million who have so far registered, only 4 million are paying up for SHIF. And the 4 million, of course, we know who they are. They are those who are in the formal sector, and their employers are actually making those deductions and remitting them back to SHIF. So we are in a situation where we are burdening 4 million Kenyans with the provision of healthcare services for the whole population, the whole of Kenya's population. So the big question is, what exactly are we doing? And then when you look at the resource allocation from the exchequer for the primary healthcare fund and for the other fund, which is the emergency, chronic, and critical illness fund, you realize that there is inadequate allocations. Because if you look at the allocations that we had in 2023-2024 for the social protection in health, we had the government, or rather the exchequer, had allocated 20 billion. But if you look at 2024-2025, the allocations were at 13 billion, just over 13 billion. So this clearly tells you that the budget cuts have gone to almost by half of what we are actually supposed to be budgeting for. So questions around, are the resources allocated for the implementation of SHIF, between one, and are the resources allocated for social protection in health really sufficient? And then again, if you look at the absorption rates for the social protection in health as of December 2024, that is what we are calling just first half of the year. The absorption rate was already at 80%. So what we are saying is, within the first half of that financial year, we've already, the health sector under the social protection in health have already spent just over 80% of their allocation, and then now leaves 20% to the allocation of for expenditure for the second half. Of course, that definitely points to an issue. Is the money allocated really sufficient? And if it is not sufficient, what really then is the issue and what really needs to be handled? So beyond that, again, if you look at the claims that are made and the remittances that are made back to hospitals by the Social Health Authority, 80% of what is taken back, what is remitted back to hospitals, goes to private hospitals. And the big question we are asking, as we are remitting, of course, we know why 80% goes to private hospitals. They have better infrastructure, they have better human resource, and their financing in terms of ensuring they're well stocked is better. So the big question is, what then do we need to do so that we are driving back the numbers to the public hospitals? Because public hospitals have been grappling with infrastructure issues, human resource issues, and of course, financing issues, and just ensuring that they are well stocked. So you get treatment at a public hospital, but you end up having to go back to buy medication from outside. So those are some of the questions that have been raised. But the bottom line for our conversation today is we're wanting to understand whether or not we are getting it right with SHIF. So this social health insurance fund, what do we need to understand about it? Do we have instances where we are saying it's actually a good thing? And do we have instances where we are saying there's something we are missing and there's a policy reform or a policy conversation that needs to be had for us to get it back on track? So to help us just unpack and understand what really is going on, we are privileged to have Dr. Brian, who will walk us through and just explain to us what really the policy reform question we should be addressing under SHIF really is. So remember, we will be on mute, but we will give you an opportunity to raise your questions at the end of Daktari's presentation. So Daktari, you have about 15 minutes to walk us through and just help us unpack whether or not we are getting it right with SHIF, and if not, what do we need to do? So karibu sana Daktari.
Thank you so much, Winnie. I don't know whether my voice is coming through clearly.
Yes.
All right, thank you, Winnie, and I want to thank the Institute of Economic Affairs for inviting me to help discuss this very, very important topic in the history of our nation, and it's been the most important issue in our country for the last 2.5 years. So I'm privileged, really, to be here. Just a bit of background about myself. As Winnie mentioned, my name is Dr. Brian Lishenga. I presently serve as the national chairperson of the Rural and Urban Private Hospital Association of Kenya, RUFA. RUFA is registered under the Societies Act. It is a non-governmental, non-profit organization, a non-political entity. We exist to provide advocacy for healthcare, and we also participate in a lot of legislative discussions. So a key stakeholder for the Ministry of Health and other state agencies that work in the healthcare space. Just also in terms of our membership, as the name suggests, we represent private sector healthcare facilities. Initially, we were focused on rural healthcare facilities, privately owned, but you are all aware that the country is also changing. So a few places that when we started 6 years ago, a few towns have now become cities, a few small villages have become towns. So there is rapid urbanization happening. And therefore, in 2023, the membership of the association decided to rebrand from Rural Private Hospital Association to Rural and Urban Private Hospital Association to reflect how the country is changing and also the change in our membership. Currently, the association represents just over 650 healthcare facilities across Kenya of different sizes. We have you might be aware, and if you're not, the Kenyan health system is organized in what we call Kenya Essential Package of Health (KEF) levels, from level 1 to level 6. Level 1 is not really a healthcare facility, but it is what we call a community health unit. Healthcare facilities begin from level 2 to 6. All the level 6 are national referral hospitals, and for purposes of the Kenya Medical Practitioners and Dentists Council, they are under the national government. Although we do have some private and mission hospitals classified as level 6, but for our purposes, level 6 hospitals are national referral hospitals. Within our membership, we therefore have between level 2 and level 5 hospitals, from what you call health centers all the way to some pretty complex hospitals at level 5. All right. So Winnie has done a great job setting the stage for the healthcare reforms. I have a slide that can help us understand. I don't know whether you've seen it, Winnie. I put it on your inbox on WhatsApp. You have access.
Yes, I do. Do you want me to share it, or you are okay sharing from your end?
Let me try and share it from my end. Now, I will run through the slides very quickly because What I want to talk about is whether we are missing or we are hitting the targets. So the slides are basically background. Okay, how do we share? Small window. I'm not sure this is what I want to share. Sorry, Winnie, if I struggle sharing, you will help, eh?
Yeah.
I'm trying to find the right PowerPoint slide. I have a number open. Okay, just give me a second. The one I want to share is this one. Okay. A window. Okay, found it. I don't know if my screen is visible.
Yes, it is.
All right, so I'm just using a presentation in-house that we usually do for this kind of discussions. So a very quick overview on the healthcare reforms that have happened. So we'll look at the Social Health Insurance Act, the transition, the key changes, the key issues which healthcare providers are struggling with, which is historical NHIF liabilities. Of course, on point number 2 on the transition, I will also mention about the transition issues that we are struggling with, and also the regulatory making powers that support the transition. Okay, so very quickly, if you look at so just for members on call to understand, we have four healthcare laws that were enacted to support these changes. That is the Social Health Insurance Act, the Primary Health Care Act, the Facility Improvement Financing Act, and the Digital Health Act. So the reform is not only about SHIF or SHA, but we have quite a number of other legislations that were passed, the other three, which also are impacting on how Kenyans access healthcare. I will mention a little bit on each of them. I'm just starting on the SHIF Act, whose objective was to enhance health outcomes and improve financial protection. In other words, the aim was to the SHIF Act intended to enhance health outcomes. So this is by increasing the number of Kenyans covered. You may recall that under NHIF, our coverage was about 23% of the population at best. And then private insurance was doing, just about 1% population cover. So the aim has been to push this number of health insured Kenyans to about 85%, which would then qualify as a universal health coverage. So universal health coverage, not necessarily 100% coverage. The threshold is about 85%. So the question is, when we say 21 million Kenyans registered, how are we doing? Does that translate to 40% coverage? For instance, if you assume that Kenya has a population of about 50 million, is that what we are saying? Or are all the 21 million Kenyans now able to access healthcare? And are they experiencing financial protection? That is something that I will mention later. So within the Social Health Insurance Act, we have those three funds which were established: the Primary Healthcare Fund, whose intention is to pay for care at level 2 to 4 healthcare facilities, and then the Social Health Insurance Fund, which pays for care at level 4. So level 4 has an overlap between PHC fund and Social Health Insurance Fund. So the SHIF fund covers for care from level 4 to level 6, with some caveats. There are some services where the SHIF fund actually extends to level 2, 3. For example, maternity services, the SHIF fund is allowed to cover for maternity services starting all the way from level 2 to 6. And then we have the ECCI fund, the Emergency Chronic and Critical Illness Fund, which also has a bit of overlap, could cover for care, especially for emergencies, from level 2 to 6. But when you come to chronic and critical illness, it then narrows down to covering from level 4 to 6 services. Now, the governance of these funds is under the Social Health Authority as the central implementing body. Now, under the NHIF, the fund was also the governing authority, essentially. So with these reforms, you have separated the governing authority from the fund. So within the law, you have 3 independent funds. Now, you may have, if you have been following recently, the clamor by public servants, civil servants, to have their health insurance back. That has resulted through a directive of the National Treasury in the creation of a 4th fund, which is the Civil Servants Medical Fund. So the Civil Servants Medical Fund is not as yet anchored in the Social Health Insurance Act, but it has been created through a policy directive from the National Treasury. So SHA, as it is now, is managing 4 funds: the Primary Healthcare Fund, the Social Health Insurance Fund, the ECCI Fund, and the Civil Servants Medical Fund. Now, the Primary Healthcare Fund, as I mentioned, for level 2 to 4, but just a key point I want to mention on this slide is what is the source of funding into this the PHC fund. So this is from monies appropriated by the National Assembly. Of course, the Act talks about many other sources, for example, grants and donations as being sources, and even counties can chip into this fund, but the mechanism through which counties can chip in is not very clearly outlined. But however, what the Social Health Authority is supposed to do is to create annual estimates, and those annual estimates should form the basis by which Parliament then appropriates funds. So one of the struggles we have had in this first year of transition is obviously we do not have any annual budget estimates from the Social Health Authority because we were just getting started. So what has been happening is that Parliament has been appropriating based on what it considers the need for the sector, and maybe using some historical data, for example, Linda Mama data and capitation data, which used to be under NHIF. So to give you context, outpatient services under NHIF were paid for by a capitation method, which is number of dependents and principal members. You're paid a fixed amount per month or per annum. So under NHIF, it used to be either 1,000 per annum per person for level 2 and 3, and 1,400 per person per annum for level 4, 5, and 6. So that was a capitation fixed amount. So what used to happen is NHIF beneficiaries would then, if they are up to date in terms of their premiums, they would then be required to select a healthcare facility, and then the healthcare facility funding would be something like X number of people times, if it is 1,000 shillings per month, then it's something like 83.3 shillings per person per month, then capitated to that facility to provide care. And this payment is supposed to be made in advance. So this information is what has been used to estimate the primary healthcare budget. Now, that is why, for instance, in the last financial year, we had a primary healthcare allocation of about 4.1, I think it's about 4.1 billion. If you extrapolate, that 4.1 billion is exactly the amount of money that was provided for Linda Mama, for instance. And now, if you look at the allocations that we are seeing in the supplementary budget, the extra tranches of money being put in, they are also based just solely on the capitation data. So under NHIF, the capitation expenditure for about 15 million Kenyans or something like that was 1.2 billion Kenya shillings per month. Per quarter. That is what they used to spend. So per annum is roughly 4.8 billion to 5 billion. So what Parliament has basically been doing is taking Linda Mama 4.1 billion and old capitation data roughly 5 billion, and using that as a guide to allocate the budget for primary healthcare. Now, obviously, we know that the registrations have ticked up. It is not the same as what we had under NHIF. And therefore, this is why, and also the benefits package has changed. So there are a bit of enhanced, new benefits that Kenyans are supposed to enjoy because of the reform. This is where now the budgetary constraints are coming in. Enhanced benefit package and more registrations. And obviously, as healthcare providers, we were not too pleased with the capitation rate under NHIF. The figures that I am mentioning, 83 shillings per person per month, were insufficient and had stayed the same since 2012. So for the last almost 10 years, that number hadn't changed. And therefore, it had not accounted for changes in the cost of inputs, changes in HR, basically the cost of care and inflation. So this had not, these reimbursements have not kept up with that. And now with the increased registrations, you can see the strain that can potentially put on the system. Now, for the SHIF fund, I would summarize it by saying the SHIF fund is essentially NHIF reloaded, okay? NHIF 2.0. Why am I saying NHIF 2.0? Because what the SHIF fund is intended to pay for is exactly what the National Health Hospital Insurance Fund used to pay for. The services, so inpatient, inpatient care, surgeries, cancer care, overseas treatment. So now, what is the difference then if it is exactly what was paid for under NHIF? So so some key differences. One is the premiums, okay? So we are now talking about 2.75% of gross as the premium, while under NHIF we had obviously income bands, contribution based on income bands. The other key change is how the informal sector is contributing. Under NHIF, we had a fixed flat rate of 500 shillings per self-employed person per month. Now, under the SHIF fund, we have introduced a new methodology, which you as economists might understand better, proxy means testing. So, with proxy means testing, you have now variability in premiums. So this is a key change there. Another key change that the Social Health Insurance Fund has over, just pardon me, I need to close a background noise here. Another key change, I hope my screen is still there, Winnie.
Yes, it is.
Did I lose? Okay, fine. So another key change that the SHIF fund has over the NHIF fund is in it where it operates. Okay, so as I mentioned already, there are limitations on which level of facilities that it operates. I should not fail to mention that the law has capped administrative or operational expenditure from the SHIF fund at 5% of contributions. So nothing more than 5%. So this is also a key difference from NHIF. We understand that under NHIF that the administrative expenses at peak had reached almost 20%, 18, 19%. They had done some, some rationalization in recent years, but the best they managed to get to is about 11% of premiums collected being used on expenditure. Now, so by law now, this has been capped at 5%. So the intention being that 95% of collections should be used on paying for the services. So this is the SHIF fund. Now, if somebody would ask, are the benefits enhanced? To a large extent, the benefits have, so by benefits, I've said the same. What I mean here is that the scope of cover is not changed much because, you have just a limited number of, it's a finite number of services that you can cover for. You cannot invent new services unless technology and healthcare changes. So that scope hasn't expanded too much. What attempts have been made, for instance, under surgeries to slightly improve the reimbursement per surgery, and that was about by 12%. and that is not all surgeries. There were also intentions which have not been implemented, for example, to cover things like implants. So if you're having an orthopedic procedure, most patients usually have to buy the implants if they're having an intramedullary nail being put or a plate being put. That was usually outside the cover of NHIF. And with the SHIF fund, the intention was actually to cover for those implants. This is something that we are still waiting for implementation. There are other things around cancer care, for instance, ICU care, which have been contentious. There are attempts recently to handle them. But in essence, the package, the scope of services hasn't changed much. What has been tweaked is some of the tariffs have been improved. But in our view as providers, they have not even kept up with inflation, for instance, or the cost of care, as I previously mentioned. A key point here, under NHIF, we had programs that covered what we call the elderly, indigents, orphans, vulnerable. This was, government-funded programs. But now, because we are requiring every Kenyan to register as a contributor, your registration as a beneficiary is contingent also on contribution to, as far as the SHIF fund is concerned. So what that means is that you have a huge segment of Kenyans who are vulnerable, orphans, elderly, indigents, for instance, who are being proxy means tested. They're ending up with some premium. There was an issue of the minimum 300 premium, the lowest premium. Hardly any Kenyan is ending up with 300 shillings. The average premium now is in the region of 880 shillings. But so you have that segment of the population that is not able to contribute to this fund, yet an eligibility criteria to the fund is that you must contribute. And previously, they had been covered under national government programs. So we had, for instance, the health insurance subsidy program, which were World Bank funded for a while, and then the previous administration took them over, but they have now been terminated under this new transition. And so those are some of the gaps we have. So these patients Kenyans are caught up between county governments and national government. We have some counties that are making attempts to address that gap. For instance, Murang'a County has a medical insurance about 30,000 people trying to cover for that population. I think Kisumu County has something similar, but by and large, most counties in the country have not done anything to address the fact that your eligibility to the SHIF fund is tied to contributions, and we have a significant population that cannot contribute. Okay, so I will skip through. No, just mention something about the Emergency Chronic and Critical Illness Fund. So this is one of what I would call, as a healthcare provider, I would call one of the key things that has the potential to transform healthcare. So this is a plus for Kenya. And one of the nice things is the creation of this fund. The intention behind it is, commendable, because the intention is to defray costs of care where your limits under the SHIF fund have been depleted, but also to really activate clause 43 of the constitution, which is, you do not want to, every Kenyan has a right to access the highest standard of healthcare. So if you are in an emergency situation, that Article 43 still applies to you. That is still a right that you have according to the Constitution. But we didn't have a way to operationalize that under NHIF. There was no mechanism for that under NHIF. So the creation of this particular fund, for instance, for emergencies, is extremely important, so that if Parliament, and this is a parliamentary allocation, if the resources are allocated, then we do move a step closer to realizing Article 43. Now, how are we doing so far? We still have challenges here because of budgetary constraints. The allocation in the 2024-2025 budget was 500 million only for this fund, which, and then we also lagged behind in governance within the Ministry of Health because we did not create regulations to activate this fund. This is one of the funds where the regulations to activate its use have not been put in place. So therefore, despite the fact that the intention is there, there's some fund allocated, we have only just begun activating it. Actually, it is yesterday that the new CS for Health mentioned that ECCIF has now been activated for cancer cases. So they are now, providing another 150,000 for people to, fall back into for cancer treatment. But we still have a long way to go because we have very many patients. For example, patients with mental illness. Mental illness tends to be lifelong, chronic illness. Patients on dialysis, for instance, this is lifelong issues. So we have a long way to go. The ambulance package is still not running actively, so that is still something that needs to be done. Now, so this fund is struggling between two things, mainly that regulations have not been put in place to activate it. And even within the SHA portal, the claim system, we still don't have clear mechanisms of how you can submit claims under this fund. So that regulatory environment and the operational environment has not been sorted. That is beside the fact that during the public participation process, the budgeting process, the estimated amount of money required for this fund on the first year was in the tune of 75 billion shillings to cover 85% of the country. Obviously, when you compare 500 million shillings versus 75 billion, we have a long way to go. And we do need to have a very sober conversation as a country on how we bridge that. Now, I will skip all this. Winnie will allow me to drop this and just paint a picture of where the health sector is right now. Can I?
Yes, you may.
Now, I want to share, so one of the things that we have been doing as an association is we have been tracking the transition. We have been doing transitional, what we call transitional scorecards. And I think the last scorecard we did in February, and I just want to share this with you so that you can see, you can start to have a picture of how we are doing in terms of this transition from a service provider point of view. So 1 minute. Just 1 second. Yeah. Okay, I'm ready. Window. Is my screen visible?
Yes, it is.
Okay, so this is a short transitional status report for a survey we carried out in February, mid-February. So this is about 5 weeks ago. Now, we'll paint for you a picture of how we are doing. So with this survey, we looked at a representative sample of about 351 facilities. As at February, SHA had formally contracted 3,993 facilities. These are the official figures. Sometimes when you listen to media reports, you hear that we have 9,000 contracted facilities. However, when you look at the official data, it paints a totally different picture. So the contracted facilities are just about 4,000 right now. So we looked at about 351 of these. And in terms of representative, these facilities covered all the healthcare associations. That includes RUFA, Kenya Association of Private Hospitals, the Kenya Conference of Catholic Bishops, and the Christian Hospital Health Association of Kenya, which represents hospitals owned by Protestant groups such as the Kijabes, Chogorias, etc. Now, I will just go down and just show you what we look at in our survey. So we look at 11 key transition metrics. We look at, for example, so SHA portal credentials and system access, training on the SHA portal navigation, SHA portal functionality, e-contracting. So e-contracting is a key difference that was introduced under the transition. Previously, you know, facilities were contracted manually. Now all the contracting is digital. We look at patient verification and registration, care provision, ease of reaching SHA contact center, provider financial well-being, and out-of-pocket payments, outpatient reimbursement model, and issues to do with regulators like KNPDC. So we have a scoring system here. Now, I can show you how the SHA was doing on the latest survey we did. So for example, on SHA portal credentials and access, the credential availability, how many facilities have credentials to access the SHA portal and therefore can log in and provide care using the portal and submit claims. So this was very high. As at February, 93% of healthcare facilities were able to do this, which was rather similar to what we have seen in previous surveys. However, we do note that although they have access to the portal, up to 62% of providers experience difficulties. And this number, unfortunately, in February had risen from 58% in December. So you can see the technical challenges like, the technical challenges that Aden Duale has to deal with. The issue of portal stability is real and it affects care. So about 62% of providers, though they have credentials, they have problems. And what are the common problems? 29% of them cite non-functional credentials. You have credentials, they don't work. 27% of them are sometimes automatically logged out of the system. And we also saw that across the country, 14% have internet connectivity issues. Remember, this entire framework is online. Everything is cloud-based here. Your patient verification, registration requires internet access. So we do have parts of the country where this is an issue. However, if you look at it overall, this is a score that has improved. So we have a 75%, although there was a slight decline here. Now, portal navigation. A good number of facilities have issues navigating the portal. And this is just an indicator of the training issues that we've had. So remember, the SHA portal is totally new. This is a very new thing, introduced in October, overhauled in November. So this is like you're building a house as you live in it at the same time. So training hasn't actually kept up, and providers are struggling with navigation. And to be even more precise, this is much more common in public facilities than in private and faith-based facilities. The training gap is real in those kind of facilities. So, and part of the reason is this, that literally all the training has been delivered virtually. And if you have internet problems, power problems, then you get to see what and also how to coordinate trainings. So a lot of providers have been requesting for face-to-face training. Now you may ask, why didn't we prepare for face-to-face training? I think a key issue that we have learned is that the transition was underfunded, or rather resources were not put in place to cover things like training, for instance. So, and at the same time, when we moved from NHIF to SHA, we are also in the process of reorganizing SHA is in the process of reorganizing the branches. So some branches are being shut down, collapsed. Employees are being asked to apply for jobs afresh. There are those who are being asked to voluntarily resign or to be redeployed to other departments. So NHIF had about 1,800 personnel. The intention of SHA is to cut down that number to about 800. So you have about 1,000, people who used to work for NHIF who will, transition. They will leave the organization, will not be retained. Now, this group of people is not in any sense motivated to support providers with training, and also there is no motivation on the SHA side and Ministry of Health side to train people whom you are in the process of transitioning. So this has created a huge gap in terms of facilities being ready and knowing how to use the portal. So portal functionality, here I want to mention a key point, what we call system downtime. And this is a common problem that you will hear Kenyans talking about, that I have registered, I am paying my premiums, I went to the hospital, I was told SHA is not working. And this is, part of what has driven the unpopularity of the reform. It has nothing to do with the fact that we have 3 funds. Nobody is really complaining about SHIF fund, PHC fund, ECCI fund. I mean, as long as they are funded properly to meet care, most people would agree that we do need to have more money in healthcare. So because our population is growing and it's changing, and the demands that healthcare is pressing. But the issue is, once you've paid your premiums, you should be able to access care. And so what Kenyans have been experiencing are things like one-time PIN delays, OTP delays, which is very common. Facilities also not able to track their claims, claim approval. So for instance, you go in for a surgery, they submit a pre-authorization request, it is untraceable. So this kind of portal functionality issues, and you can see the score was very poor in February. So these are issues that have really dragged down the reform. E-contracting really picked up. About 83% of facilities had signed their electronic contract. As at yesterday, the Social Health Authority has written to all hospitals and telling them that if you have not signed your e-contract within the next 2 weeks, you will be delisted. So this is a very important part, and it is very likely that a provider near you or somewhere might find that they are not able to offer you services because they have not complied. Now, another key challenge that Kenyans have been facing is around verification and registration. So here is also very high, 83% of facilities in February telling us that there are difficulties. And this had actually ticked up from 79% in December. And what are the difficulties? So patient registration, again, one-time PIN delays. Now, I don't know how many of you are aware that the entire IT infrastructure that is running the SHA model, as I said, first of all, it is a whole new infrastructure, but that this entire IT infrastructure has been, subcontracted by Ministry of Health, or rather, contracts have been given to third parties. So the Safaricom-led consortium is the one that is responsible for this IT infrastructure. And so therefore, a lot of these issues fall directly in their they fall directly in their hands, in their domain. Now, why this has happened is a complex question. There's an issue of a rushed, we talk about rushed transition. As an association, for instance, we wrote in February of last year to the then Cabinet Secretary, Nahomicha. And in our view, we advise that the transition is going to place a lot of demands on the health sector system, and we proposed a first transition of 2 years to allow all these things to be put in place. However, that is now water under the bridge. So we had a rushed transition, and the IT infrastructure was not prepared. Now you have end up with this kind of issues like OTP delays, which was a leading time. So you have somebody registering, and one of the things we did with the current reform is that immediately you register and you pay your first premium, you are eligible for care. Obviously, you as economists, you might find a problem with that because the moral hazard and encouraging people to pay. So somebody is sick, they pay their premium now, they get the treatment and they never pay again. Of course, those kind of risks have been built into this architecture. But when you're trying to register and the OTP doesn't come 2 hours later, 3 hours later, 4 hours later, you have a child who has a fever, and the mom is there, so they give up. Okay, so they simply give up and end up paying cash. So this also was this technology failures have been a big driver of out-of-pocket payment as well. 59% of providers told us, especially in rural areas, this system is highly dependent on the registrant having a phone. So we have up to 59% of providers telling us that the people who come to their facilities don't have phones. Okay, another issue that was happening is the issue of missing dependents, and this was also a challenge that was brought out by governance. You may remember that NHIF, people who are under NHIF in the NHIF database, who are at some point about 4 point something million Kenyans, were migrated directly into the SHA portal without registering. Now, that migration ended up having technical problems because while principal members were migrated, dependents were not migrated. So you get to a hospital and the child is not in the system. And so all these issues have affected the transition. So this is one of the issues that scores very poorly. And we also are tracking care provision to SHA beneficiaries, and specifically interested in outpatient services, maternity services, and surgical services. And here's what we found out. Outpatient services were the least popular, with an approval rating of about 37% in February. And I will explain the reason for this. Maternity services were doing very well. One of the most popular services, maternity services picked up. But you may ask, why is maternity services doing well? It's because there's a lot of support for maternity services. And, the lessons we learned from the Linda Mama package under the NHIF. So this is one of those where transition has been very easy. But remember, I want to point out here that I want to create a link between money and services here. Outpatient services, as I mentioned when we started, is they are paid for under the primary healthcare fund. What is the problem with the primary healthcare fund? Parliamentary appropriation. Okay, number one. Number two, the transition has introduced a new model of paying for outpatient services that maybe you as economists and people who deal with such issues, you might want to dig into and try and help us as health sector understand this model. The new model that's been introduced to pay for outpatient services, what is called the global budget capitation. Now, just to give some, to flesh out this point, the global budget capitation works in this way that let's take Kajiado County has 270,000 registered SHA beneficiaries. I'm not saying contributors, registration. We have to draw a line between contribution and registration. This is one of the key. And I think we needed this. 20 million people registered, about just 3.3 million, maybe ticking up towards 3.5 million contributing. So there's a big gap. So here, we are not talking about the 3-point-something million contributors. We're talking about the 21 million registered. So if you have 270,000 people registered in Kajiado under SHA, how this model works then, this is where the story of 75 shillings or 900 shillings per person per year comes up, 75 bob per month. So this model therefore does, we can round off this to a nice figure of say 300,000 people in Kajiado. So it just therefore does 300,000 times 75 bob, and that is the primary healthcare budget for Kajiado County. Now that's something like 21 million. So this budget is fixed. This is a fixed budget. It doesn't expand. It doesn't change. It's a fixed budget. Now, all the primary healthcare facilities have to share this budget. Now, this has created significant challenges. One, it took a while for the ministry and SHA to figure out who is eligible. Okay, so eligibility took a while for them to figure out. The reason being, why I mean by eligibility is this: you have to identify a Kenyan as a resident of Kajiado. Okay, so in other words, so what if I come from Narok and I go to Kajiado for outpatient services? Do you turn me away? Okay, sorry about that. Am I still audible?
Yes, you are.
Sorry. So the issue of identifying who is eligible became an issue. So facilities were very cautious to provide outpatient services because, am I going to be paid for this person? And I have no way of verifying within the SHA portal that this person before me is truly a resident of Kajiado. So that mapping of Kenyans and tying them down to counties had not been done. And up to this point is maybe they have, they were running some pilot this month, so maybe it is working. So because of this, providers just shied away from providing care. Secondly, of course, there were concerns about the very low reimbursement. As I mentioned, under NHIF, we had 1,000 shillings per person per annum for level 2 and level 3, and 1,400 shillings per person per annum for level 4, 5, and 6. Now, under the transition, we have dropped all that down to 900 shillings. Already, hospitals were struggling with 1,000 and 1,400. Now, compare that to 900 shillings. So, again, another reason why providers shied away from providing outpatient services under the SHA transition. So, if you walk into a hospital and you are registered, you will most likely be asked to pay for cash for outpatient services. So, this is another reason why this has done very poorly. So, essentially, and well, the challenge I'm putting here is that if you postulate what would happen in the near future, is that at some point you will register 85% of the population of Kajiado, and then that budget will stop growing. So once you say, let's say the registerable population in Kajiado say is 600,000 people. Once you register 600,000 people, your population is done. I mean, your budget is fixed at 45 million shillings per month for outpatient services. It can only grow if the rate of your population growth, your population growth rate supersedes, let's say, growth of expenses. So we see a future where, because of the new model under outpatient services, providers can only sustain services at the expense of each other. It is basically, the financial model here is competition allocation. If I can beat you, because we are all competing, remember, we are all competing for the same basket. If I can beat you, then I will be able to survive. So I can only do better at your expense. This is actually what this model will create. And what we foresee happening, and maybe this is where I think maybe economists can look into this. What we foresee happening is eventually, first of all, for you to get a bigger portion of that basket, you are going to induce service, which is, I think, probably the intention of the national government was to induce service. So providers will compete to provide unnecessary care so that you can register that I saw more people, because as the fraction of your reimbursement, it depends on your number of visits. Now everybody is going to do that. Now, as everybody does that, sorry.
Sorry for that. Could we maybe close up in another 10 or less?
Yes.
Thank you.
Yes. Thanks for that. So I think I want to just clarify on this point, that as providers compete to increase service, you will have unnecessary care, but eventually it will result in each provider getting less and less reimbursement. And ultimately, the cost of that will be, poor care for Kenyans. So this is something that we are really concerned about. Now, we have had trouble reaching the SHA contact center to solve problems. This has been a big issue. As you can see, about 74% of providers can't reach the SHA contact center when we want to sort issues. A big issue that we have been in the news about has been the issue of historical NHIF liability. And maybe I should mention this as I come towards the end, that what is the link between historical NHIF liabilities and the state of healthcare? So I will just pull that down. This report, as I close, to show you where we are as a health sector. This is a survey we carried out. This is our most recent one in March. This is just 3 weeks ago. And this is, we're looking at the business environment now, not the SHA transition. And I just want to point out the key findings. What is the link between cash flow, historical liabilities, which if you've been following, healthcare providers are owed to the tune of 30 billion shillings historical debts under NHIF. And therefore, they are cash starved. As you place more demands on them for the SHA transition, they don't have working capital to pay salaries and things like that. So what is the impact? We found out that 82% of facilities, they have scaled down operations in the past year. And what is most affected is clinical services, up to 66%. And this is largely affecting the medium level facilities, levels 3 and 4, which form the bulk of our health system. 90% of our healthcare providers are here, and about 82% of them have scaled down. Now, we also are seeing human resource contraction. 85% of facilities have reduced their total staff, and some of them have restructured departments, frozen hirings, or shifted to locum or temporary staff. We've also had increase in voluntary resignations, about 70% of facilities, most notably at the most important facilities, that's level 4s. And who's most affected? Nurses. Nursing staff are voluntarily resigning. Obviously, you know the trend for brain drain around our nursing staff, and this is very clear. Um, Again, volatile payroll, and this is something that you guys might be very well aware of, especially new government statutory deductions, things like the housing levy, of course, the SHIF fund, the NSSF deductions. We are also dealing with licenses. To open a healthcare facility today, you need 17 different licenses to open. All these are, affecting how the health sector is working. And then we have generally the uncertain future. About 61% of providers expect to reduce their staff even more, and 1 in 4 of healthcare facilities are considering selling their business, especially level 2 to 3 providers. So I try to paint a general picture of what is happening in the healthcare system. And I think how we get out of this is we do need to, go back to the basic issues, go back to answering the question of allocation of resources, and bring more sanity into how we are conducting the transition. And remember where our focus needs to be. We spent 45 billion per year to finance level 6 hospitals. Have we ever asked ourselves, these level 6 hospitals, why do we have to pump money there? And yet, even today, if you go to any level 6 hospital, you will pay out of pocket in addition to your cover. Why are we subsidizing level 6 hospitals? 45 billion to level 6 hospitals is enough to provide primary healthcare for all Kenyans. These are some of the things that we need to ask ourselves. How do we shape healthcare and make sure that Kenyans get the healthcare they deserve? Thank you guys for listening.
All right. So thank you so much. Thank you so much, Dr. Brian, for just walking us through and taking us from the transition journey from NHIF to SHIF, and also just given the surveys that you've conducted, highlighting the issues that Kenyans are going through even as we adopt SHIF, and you've raised issues around of your transitional scorecard about the mostly around the portal, its sustainability, the navigation, its functionality, and these are issues that you walk around and you'll hear Kenyans actually raising, because initially you raised an approval to NHIF for a service to be conducted, or a procedure to be conducted. You'd actually, if there was a delay, they would actually just have to call NHIF, and an approval would actually be fastened. But with the current situation, you hear Kenyans saying they don't even know which number to call, who to call, and if you walk to the SHA offices as well, they're also as as lost as we are. They also don't know who to call and who should do what. So, I mean, the transitional scorecard is something that you should be able to share so that people can read, and even policymakers should go through and just see what really are Kenyans worried about as far as that transition is concerned. And it's interesting you raise the issue of transition on and how fast we transition when we are carrying out a reform. It's not the first time we are struggling with a transition after a reform. Most of the times the government is conducting a transition. There are normally teething problems expected, but the big question then is, how do we handle those transitional problems? And that is where the issues now start coming up. That is where citizens start having doubt with whatever reform you want to carry out, because the grievances or the issues being raised with the transition are still not addressed and add up to the reason why we were conducting the reform in the first place. And then, of course, you've also raised issues about the regulation around the implementation of SHIF, and also the operational component, which I've spoken about. So as we go back, and those are probably the misses we are having with NHIF. But interesting to hear that you've mentioned that the emergency, chronic, and critical illness fund is actually a good thing and is something that you would actually applaud if well implemented, because the benefits to the citizens are actually immense, seeing that it wasn't existent under NHIF. But that said, again, as we speak about the emergency, chronic, and critical illness, together with the primary healthcare fund, remember that for you to benefit from those two, you actually have to be a contributor under SHIF. So again, you see that leaves leaves a question of doomed if I do, doomed if I don't. So those are questions that we really need to look at. And then the main worry I believe Kenyans are having as far as SHIF is concerned is that we are being burdened with very high deductions and having to, our employers and those who are doing personal remittances, having to remit funds. And the issue is we are not accessing healthcare, and the government is still failing to improve healthcare service delivery. So even as we engage and as we continue to have this conversation, I believe those are some of the questions that we will be hearing people on the other side raise, because there's no need for you to be making those remittances and you still can't get access. You're still being turned away. For you to get an approval, for instance, it's taking a long while. So in the end, because you need to get whatever needs to be done, you end up having to go back into your pocket for you to make that payment and get the service done to you. So that's why we asked the question, is it a hit or a miss? And of course, we understand from your presentation, there are hits, and of course, there are misses that we still need to have conversations around. So I will leave that at that and allow our listeners to come in and also just raise questions or contribute to the conversation. What do they think? Do you agree that we are on the right track to universal health coverage? And do you think we are, the government is improving healthcare service delivery or not? And if, what are your reasons for that? So kindly, if you have any questions, if you have any comments you'd want to share, this is the time. You may raise your hand and we'll give you an opportunity to unmute yourself and ask your question. But in the meantime, Doc, I can see Jairus has asked a question on the chat box as we wait for other people to prepare their question. So Jairus is asking, you mentioned that we have about 4,000 contracted facilities. What is the overall share of contracted facilities, and what does that mean for access to health insurance coverage? That's Jairus. And then Florence. Florence is asking about the perception and the resistance that transitioning to SHA received, and were the resistance issues about SHA managed well before the transition? If so, why are there so many complaints countrywide? And then, can we call SHA a mismanaged change process? And what is happening to the contributions as people continue to pay from their pockets, which is a very legit question, because remember, we would also want to understand, as we transitioned from NHIF, we had already made contributions. What happened to that share of contributions that were made under SHA, and now we are here under NHIF, and now we are here making contributions under SHA? What was that transition like for that financial aspect? So Dr. if you could respond to that, and if there's anybody else with a question, please keep typing them. And if you want to voice it, you can just raise your hand and we will give you an opportunity to ask your question verbally. So Dr. if you'd respond to those as we wait for others. Thank you.
Now, this is a very good question, Jairus. I think I want to say this, the problem, we have a very interesting problem in Kenya. The total number of facilities registered with the KMPDC, Nursing Council, and Clinic Officers Council are slightly over 15,000, of which about 8% are FBOs, another about 47%, No, 47% are public and 45% are private. So the public-private is about 50-50, but you see the vast majority, if you take, are in private hands. The FBOs and the private would have the lion's share. But this is not really the problem. I should ask a question this way, Jairus. Do you think in a country of 582,000 square kilometers, slightly just less than 100,000 kilometers less than the size of Texas, and with 55 million people, we need 15,000 facilities, and they are growing every day. Uh, what I want to point out to you is that a vast majority of these facilities are just physical structures, and a lot of them have ballooned since we had devolution. And with devolution and the counties trying to, benchmark, the standard for you doing development is to open something somewhere. So we have a mushrooming of healthcare facilities that are not necessarily providing care. Now, again, let me give you a more interesting perspective. Out of the 4,000 contracted, these are the ones who have, these are 80% of them are private and faith-based. The reason being, government facilities generally don't contract. They just assume that they are part of government. So they are there. They are there. That is why they keep saying 9,000. So you add 5,000 government facilities there, which don't generally contract. But there is an issue, a more deeper issue there, which is, where is the money going? Out of this 15,000 facilities, let's assume all of them were to be contracted by NHIF. Let's just assume all of them were, by SHA rather. You will find something very interesting. You will find that the facilities that actively submit claims to SHA are just below 3,000. In fact, our numbers say about 2,980 or something like that. So these are actually the facilities that are seeing patients and submitting claims. So what are these other 12,000 facilities doing? Now, and who are they? One of the things that we have come to know is that many of them are government facilities. So they, and just to tie into what Winnie was saying about 80% of the money going to private hospitals. It's slightly less than that, it's about 60%. Number one, government facilities don't care about submitting claims. You walk in, you walk out, nobody wants to follow money. After all, salaries are already paid by Exchequer, electricity is paid by our taxes, water is paid. Drugs we will take from KEMSA, which we will not even pay KEMSA. So there is a degree of apathy on our public sector when it comes to efficiency of managing their resources that contributes to this. And again, you can even go more granular to that. Lately, SHA has taken to publishing who it is paying. Now, we have analyzed who SHA is paying. I would submit to you, and I want us to think about this. 46% of the money that comes from SHA, it is circulating in Nairobi and what you would call the Kiambu area, a bit of Murang'a, Kirinyaga. This is literally the central part of Kenya here plus the capital. It will consume close to 45% of that money. Now, why am I raising that point? Of course, this is also the region where you have your best facilities. You just walk from about a 75-kilometer radius of Nairobi, and you will get to Kijabe, PCA, Kikuyu, and then you have your Nairobi hospitals, the Matters, which, if you look at the payouts, for instance, the Kenyatta National Hospital is here, Kenyatta University Teaching and Training Hospital is here. The point I am trying to make is that, yes, you have 4,000 contracted facilities and 15,000 potential facilities, but the distribution of healthcare resources in Kenya is extremely inequitable to the extent that if you look at the money Busia County, for instance, or even Kilifi or Kwale, let's even pick the other side of the country. If you look at the money as a county they received as a reimbursement total for their facilities, it is less than the money that a single hospital in Nairobi got. one hospital or a single hospital in got. So we have a serious problem there that requires addressing. We are spending, although we are collecting this money doesn't touch the people. So this is why Kenyans generally feel shortchanged, because the resources that we collect, it's actually a lottery. We collect, but we pay a few. We collect from many, but the money goes places. So that is on that issue. In terms of your question of health coverage, now, do we ultimately need to rationalize facilities in this country? Maybe we need to rationalize. We need maybe to decide, how many facilities you can have per given population. Maybe we need to do that. But this is a serious conversation we need to have as a country, because we have all these ballooning so-called facilities around the country, nothing happening. But then we also have concentration of resources in specific parts of the country for healthcare. People outside those parts of the country do not receive those resources. Now, on the issue, there's a question raised by Florence, were the resistance issues about SHA managed well before the transition? So the short answer is no. A lot of people raised issues about the transition. And part of it has been the political rhetoric around the transition has been unhealthy. Because, for example, if you say, let us delay the transition, what the backlash you get is that you are the beneficiaries of the fraud of NHIF. These are people who used to eat money from NHIF. I will say something about the fraud problem. The fraud problem exists, but it is not as massive as has been painted. Unfortunately, those have been some of the wrong sound bites. We have data from NHIF. Data from NHIF shows that only about 8% of claims submitted to NHIF were being investigated for fraud. About 90% of claims submitted were considered clean. And remember, they are verified from the branch, from the facility all the way to HQ. So the pushback when we said, can we have a slower transition? For example, something else that has made why Kenyans are really crying, and it has to do with premiums. Proxy means test. To check the characteristics. Sorry guys about that. Sorry about that. I was saying proxy means testing is unpopular. Why? Because Kenyans are lying. You cannot ask a Kenyan, how much land are you on? And then a Kenyan says, I am on 5 acres, and then they pay 2,000. After some time, people realize, I need to say I'm homeless so that I can pay 300. We told them, you're not going to get the informal sector to contribute this way. Remember, we have an intention to collect about 300 billion rather, under the 3 funds. But a lion's share of this contribution is supposed to come from the informal sector. 80% of the money is supposed to come from the informal sector. The 3.5 million Kenyans who are contributing to SHA are employed formal Kenyans. So the informal sector has totally abandoned the transition. We need to ask ourselves why. Part of the reason is proxy means testing. Okay. And so what is proxy means testing doing? So people are going there and they talk about how much money they spend on school fees, whether the house has tiles or it has piped water, electricity, or they have a car. And a lot of people are gaming the system. Okay. They are deciding to say, and once they game the system, they get the lowest possible premium. And after they pay the first premium, they access the most expensive procedure immediately, and then they drop. Sorry, I keep getting interference. So these are some of the issues that are creating problems, just to respond to Florence. So the second part was SHA a mismanaged change process? Certainly, there are things about the change process that were mismanaged. As I've mentioned in the surveys, the IT infrastructure, the total overhaul of the IT infrastructure should have taken more time. And did we need to overhaul it? For instance, under NHIF, we had already done biometric registration of over 8 million Kenyans. Now we are relying on one-time PIN, and you can see the problem one-time PIN is causing. Why did we not ride on that great work? And it costs us a lot of money, by the way, to do biometric, deployment. So some of the questions we were asking, why did we doubt the biometric data? And in place of the biometric data, replace it with one-time PIN, which has more vulnerabilities. Yes, there were issues there that were another issue that was mismanaged was Parliament was mismanaged. The parliamentarians did not understand the implication of pushing for 85% coverage, the budgetary implication. And therefore, when they were appropriating monies and they put 4 billion, 1 billion, 500 million shillings, did they really understand that the exchequer was responsible for primary health and that they would need to reprioritize allocations? So yes, there was a lot of this that was, there were court cases around this. Public participation was not sufficient. And we also have a situation where public participation was treated as a window dressing affair. You are allowed to participate, but your opinions don't have to be taken in. So we did have a lot of issues around that, and we could have definitely done better.
Thank you so much, Dr. for responding to those questions. There are no other questions on the chat box, but if there's anybody who feels they have a question or a comment that they would want to voice, kindly raise your hand. We'll give you an opportunity to do so. Marion has raised her hand. Marion, if you could please unmute yourself and ask your question kindly.
Okay, thank you so much. And thank you to Dr. Lushenga for quite an enlightening presentation. I'm a researcher of social policy, and I agree with you on a couple of things, but then I have a question or two. I think it's important that that universal healthcare, and especially healthcare and even universal healthcare, is approached also from the political angle and the social angle, because it's all about universal healthcare is about solidarity, collectivism. It's about putting resources together so that all people have access to quality health services when they need them without the financial hardship. But I get the sense that these are the aspects that were omitted within the public participation process and so on, yeah? That we looked at it, we chose to look, or let me say the government chose to look at it, or looks at it even now, from the economic perspective and a medical perspective. Yet, a large part, and I think a large part of universal healthcare, if you're to achieve a universal healthcare as a country, there has to be the political process of participation of citizens, you know, engaged in it. And that's when you can have a proper health system where you know it's about solidarity, because not all of us can pay the same amount, yeah? Not all of us can pay the same amount. Some of us can pay more and so on. And that's the purpose of actually universal healthcare, that you're able to cover others. And so I agree with you that the participation has largely been left to, you know, maybe economists, people who talk, you know, the language of money, and people who are in the medical field, but then there hasn't been any engagement on the politics and also the social parts of universal healthcare. I also agree with you about the proxy means testing. Anywhere you have a proxy means testing, people will find a way of beating the system to pay the least and gain the most amount out of it. And so my question is, do you think it would have been better if we had a single payer system, you know, where the money, rather than the money coming from individuals, yes, at the end of it, it all comes from individuals through taxation, but then you have only a single payer in the form of government funding the UHC rather than what we have. Because my fear is that what we have is that we will end up with something like the American system. Let me use that. We'll end up with something like the American system, where if you look at the per capita, what you're spending per capita per person for UHC is so much. Yes, yet we have such bad health outcomes. You know, what do you think? What do you think about that? And I think also another question is, we had the UHC that was started in the last political regime. of President Kenyatta, where we had 4 counties that had pilot UHC. What are the lessons? You could have been engaged in the policy process and so on. What are the lessons that we learned from that? You know, we had the 4 counties. I think there was Kisumu. I can't remember the other 3, but it was basically a pilot that was to lead to UHC. Yeah, which I don't know. It was abandoned, yes, by the current regime. But what are the lessons that we are carrying forward from that? Lastly, I think studies had, from social policy angle and so on, some of us had conducted studies, and that had indicated that NHIF was actually subsidizing private facilities. Then that most of the money was going to private facilities rather than government facilities. And some people have said maybe what's going on, there's backlash by private hospitals because now they're not able to cope because the money is being now taken to public hospitals, and so maybe private hospitals is a backlash to that. What is your view towards that? I know you've talked about UHC will definitely create a demand on health services, and we all agree that the supply side has not been built well enough, and therefore there is need to have the private facilities to do that. So what would be your reaction to the questions and the comments that I made? Thank you so much.
All right, thank you so much, Marion. We'll have Kwame. Kwame also has a question or comment. So Kwame, please unmute yourself and proceed.
I hope you can hear me.
Yes.
Okay, fine. Thanks a lot, Dr. Lishenga, for an educated presentation. I have 2 questions. The first one is basically, I have to push back on your claim that fraud was very limited, and you say only 8% of those claims were suspected, and that is from the NHIF itself. And I would say that, well, you don't expect somebody from NHIF to say our claims record is high, to be honest. And you being part of the representatives, and I don't question the integrity of your organization, some of those claims would have probably been claims that were made by your members. So I think you need to be a little bit more cautious in making those statements about an 8% or only 8% of claims. I'm a little cautious. I think we need to reinterrogate those numbers. And to make it look like I'm not just saying that for the purposes of itself, let's look back at the Auditor General's reports, which is external reviews. And in the year 2023 alone, the NHIF claims, the Auditor General found out that duplicate claims with unsupported numbers amounted to about 9 billion shillings. 9 billion from an organization that was managing at that time close to, is it 94 or 97 billion, depending on which figures were available at the audit reports. So I would like us as a Kenyan who contributes and actually supports the solidarity that it requires for health systems to be provided to say that no, I think that fraud at the NHIF was massive, it was deep, and it was widespread. So maybe you need to give me a different view about what that is, because 9 billion shillings for duplicate claims, forgetting about other claims that weren't supported. If you look at the Auditor General's report on the NHIF, I mean, it's very sorry reading. So I'm a little more cautious than you are, and I'm a Kenyan citizen, so perhaps there's something. So you need to assure me that the systems were much, much better than what the Auditor General found. But an internal report from the NHIF itself, it's just like we at the IEA, if we gave our members a report which was concerned by ourselves by saying, look, we don't have problems, we actually manage our systems well, and we make sure that we do all those things, that would not be as acceptable. So what the Auditor General tells me that there's a lot of administrative work to talk about on the fraud side at the NHIF. And I'm not too sure that SHIF has necessarily corrected it. So that's the first thing. And then the second one is on the question of the benefits package. I agree with the idea of the universal healthcare. But I think the benefits package, remembering that the incomes that Kenyans have is very, very limited. The benefits package, in my view, will always leave us with discontent, because I think it's promised so much benefits. And what's going to happen in the end is that we're going to raise people's expectations. And given the amount of money that Kenyans have in terms of the incomes in itself, maybe a more disciplined or a more realistic benefits package would be useful. I also accept that providers of the service coming from medics and that have their own interest, obviously. The more money that's available in the sector, the better it will be in terms of incomes, but without thinking about how to use those resources most efficiently and most effectively, Kenyans will always be disappointed, because running universal health coverage systems, including in countries that have 30 times more income like than Kenya, such as the US, will always lead to outcomes. So we cannot use the money and the amount of money going into the system as a check. I think we need more efficient ways to actually ask, how do we use the resources that are available in ways that give us the best outcomes? And you said, and at this extent, I agree with you, that perhaps concentrating on sending more resources for primary healthcare and those other services are actually more useful. But it's also, again, about how do we balance between level 6 or referral hospitals and the primary healthcare, which is where most Kenyans receive their services from. Thank you.
All right, so thank you, Marion and Kwame, for your comments and for your questions. Dr. Brian, if you'd respond to Kwame and Marion before we go to our last set of questions. Karibu.
Thank you. I hope you can hear me.
Yes, I can.
Yeah? Okay. Right. So maybe I will start with the. So for Kwame, I missed your last point on primary healthcare. Maybe you will repeat that. I got a weak connection on that one, but I want to just say something about the fraud problem. If you will recall, I have looked at the Auditor General's report about the issue of duplicate claims, for instance. If you recall that we had quite an inquiry on the issue of fraud sometime in 2023, and covering the issue of unnecessary surgical procedures or ghost surgical procedures, and the issues of around Edu Afia, for instance. And what that process unearthed was, fraud to the tune of about 178 million Kenya shillings, which, if you consider that in that year, NHIF collections were around 78 billion, you can see it. So maybe there was, a failure in identifying the fraud or, cover up. But I also want to mention that the biggest driver of fraud, and this is still going to be the case with SHA, is actually the issue of medical necessity. When do we determine medical necessity? Because we have quite a bit of spurious procedures. And let me even let me bring this point closer home. Maybe Kwame and I can bridge the gap between us. If you look at the most recent SHA payments, for instance, just about 100 facilities account for 60% of the payout. We're talking about the total number of facilities that received money were about 2,000, 3,000 facilities, and 100 of them account for 60% of the payout. Now, under NHIF, we had about the same number of facilities, and this is data NHIF has, that SHA has, that account for 60% of the payout. So if we are serious about addressing the fraud problem, it's actually very easy, because if you are paying out 60% of your fund, and it actually rapidly grows to about 80% of the fund by the time you are at the top 150 facilities. You are talking about almost 75, 80% of the fund. So these are not many facilities. So we are saying that something like 2,800 facilities share 40% of the fund. So if you narrow down to this 100 or so, 150 or 200 facilities that account for our biggest payouts for money, this is really where you would find the fraud problem. And what do you find when you look at this top 100 150 facilities. One, all the national referral hospitals are there, all our large private hospitals are there, and you can pick facilities in Mombasa, Kisii, Kisumu, Uasin Gishu, Kiambu that are dominate that list. If you look at it, how do you find fraud in there? And finding fraud in there, from what we have, what we know as a sector, is if it is, I mean, obviously it is happening. Global figures are like about 23, 24% of all claims are fraudulent, medical claims. It is happening, but in what manner is it happening? And I submit that we have a continuous weakness in auditing of medical claims or pre-authorizations. And this also has to go down to how we structure claims departments within, let's say, SHA. If you look at the Act, the Clause 35, they created something called a Claims Management Office. And in our submissions to them, we told them that the Claims Management Office must have a medical committee within that Claims Management Office. We have a big challenge with the way we staff that department. Because we don't staff with the people who can decipher what is happening in a claim. So if you have a knee replacement, what is the criteria for is this actually a knee replacement that happened that was necessary? So these are the things that are driving this. Issue of duplicate claims, of course, we can handle duplicate claims through proper ICT systems. But the point I'm trying to make is that the fraud problem, while it exists now, we have data under NHIF that what I was quoting about 8%. Those were the volume of claims that were under investigation for possible fraud. Now, why did a vast majority of claims, let's say another 15%, pass under the radar? That why are they not able to be flagged? And this is really where we need to people are talking about now the SHA system will have AI to detect, but I think it needs to go much deeper than that. You do need to build capacity within, and I think private insurances have been trying to do that. Staffing themselves with the medical officers, specialists on their panels who can be able to decipher this. But it's a problem that requires us to have the right expertise at the right place to be able to detect it, because it is actually not very easy to detect when it is happening. Now, on the issue Marion raised about private versus public claims, I think I tried to address this, putting it this way. So one of the issues we have on the private side, on the public side, is that the public side, in terms of volume, they see the larger proportion of patients. But they get the lesser proportion of reimbursement. And the reason for this is that, of course, it is obvious economic incentives here. The private sector is very aggressive at claims management. They are very aggressive at pushing for their payments. This is a challenge you see on the public sector. So one of the things that, and sometimes I advise counties on how to restructure their health systems. And one of the things that I have told those counties I advise is that you can't have your health system, you have a director of medical services following NHIF claims. They don't know what to do. You do need to have a claims management office within the county that specifically is staffed and it deals with claims, and they pursue claims. We find very strange things. Public hospitals rarely submit more than 15% of claims of the volume that is going through, and so this might actually be an indicator of these disparities in payment. So this is a problem we have. It's a real problem. There's no large incentive on the public sector side to actually make sure they are getting proper reimbursement. There is over incentive on the private side, and so this is part of what is contributing to those disparities. The other thing is that when private sector players get into the market, they tend to invest a lot in level 3, level 4 facilities. Faith-based organizations invest a lot more in level 5 facilities. And if you look at the top 150 or top 200 facilities, you will find they are dominated by private sector and faith-based facilities in terms of payouts. And If you look at the KEF categorization of those facilities, they are level 4, level 5 facilities, private, faith-based. So where are our county hospitals, our sub-county hospitals, and our county referral hospitals? They're generally missing from that number. What you do find there on the public side is the national referral hospitals, and that is it. So this is, part of the structural issues that we have to deal with on the public sector side.
All right, so thank you so much, Doc. We have the last set of questions, one on our chat box and the other will voice. So Oscar is asking and giving an experience, followed by a question. So it's unfortunate that the majority of Kenyans struggle to afford the minimum monthly SHIF contribution of 300 shillings, and some patients have also reported experiencing system hitches such as delays. However, my cousin recently paid 5,400 shillings for an annual cover, and when he was admitted to a level 5 public hospital for 2 weeks and underwent a surgery, he didn't pay anything. Do you think that they are fairly trying when it comes to inpatient services? And probably this is linked to you saying that we've had instances where patients are only paying for when they want, they get to hospital, they make the payment and they get treated, and then they don't make the consequent pay-ups. So that would be interesting to hear you respond to. And then, of course, let's hear the question from Fred. Fred, if you could unmute yourself and ask your question.
Yes, thank you very much, Winnie and Dr. Lishenga. Dr. Lishenga, thank you for a wonderful presentation. Initially, I was skeptical about SHI and SHA, but now I'm more confident that it's going to work out very well. Thank you very much. So my question is on based on the transitional scorecard, which you shared, which you talked about. And the second point was on training. We realized that some of the staff were not well trained to handle this system. So I have a suggestion to make. If there was a private organization that is able to come and work together with RUFA to support the government in training this staff and also setting out the biometric system, essentially trying to support the entire infrastructure, would this be possible through RUFA? Because this is a wonderful system. It just has its teething problems. And of course, the other that you mentioned was the phased transition, which should have been carried out because the infrastructure is incapable of taking up everything at once. So my question and proposal is, if there's a possibility to work with RUFA to help mitigate some of these problems that are existing, is there room for that? And if there is, maybe we could have this conversation later. Thank you very much.
All right, thank you, Fred. So I'll start with Fred. Fred, certainly there are opportunities. Of course, it requires us to collaborate with the consortium group because training is part of their terms of reference. But from our conversations with them, yes, they are looking at subcontracting third parties to do continuous training, and I will be happy to, and Winnie has my email contacts, and we can be happy to take that conversation. There is opportunity. There are also a lot of changes that are still happening. We are still not done with the changes. The SHA portal, as it is, as we understand it, is a temporary fix. Where the government intends to move is into the health information exchange or the digital health superhighway, something which they have been building, and I think they are somewhere at about 60-70% done building that. Once the HIE is in place, it's going to be a new round of training and onboarding of facilities that's happening, and therefore that presents certainly opportunities there for people who are prepared to take on those opportunities. So that is something we can talk about and also point you in the right direction as to where the opportunities are. On the comment by Oscar on the chat, I want to say, just want to say two things. One, that every time I'm asked whether SHA is working, one of the most difficult questions I'm asked. So, Lishenga, tell us, is SHA working? I always find problems answering this. I'll try and answer it this way. What is working within SHA was working under NHIF for now, okay? Whatever was working at NHIF is still working now within SHA. So for instance, your cousin paying 5,400 shillings per annum is what paying, you know, lesser than the about 450 shillings per month. So your cousin is receiving care that they would have received anyway under NHIF, under the NHIF cover if they were paying 500 shillings. Now, the second part of your statement there is, you know, 2 weeks hospital stay, they didn't pay anything out of pocket. So obviously that is, you know, something you're more likely to find in the public sector than in the private sector. And for some of the reasons I have given. So what is working within SHA right now is SHIF, the SHIF fund. The SHIF fund, which is the only fund that is somewhat funded. We are talking about 6 million or so last month collected from 3.5 million or so Kenyans who are contributing. That particular fund is the one that is working. Where are we struggling? We're struggling with the primary healthcare fund, which is a state-funded fund. So the experience will be very different if you were to ask the same question to somebody seeking outpatient services. We are struggling with the ECCI funds. Personally, I have, you know, a sister who is, you know, going through cancer treatment, and they're a civil servant. They have exhausted the entire civil servant limits, and we are paying cash. You know, we are now having to fundraise. Ideally, if you look at how the act was written, the ECCI fund is meant to defray costs of care after depletion of the SHIF fund. And as I mentioned, we started that fund, the regulations around it, the operational issues have not been put in place. It's only yesterday that we had the new CS saying that they have now activated 150,000 shillings under the ECCIF fund for cancer cases, extra money. So, and this is why, you know, if you ask yourself, what was the reform about? You know, the biggest issues that the biggest changes that the reform brought were these two new baskets, the primary care fund and the ECCI fund. These are totally new. And these are the two funds which are having the most teething problems. The middle fund, the SHIF fund, which is, as I mentioned, NHIF 2.0, has, you know, a lot of lessons, legacy that is carried over, and it's certainly doing a lot better than this one. So when we do our advocacy work, we tell the ministry, we tell government that, look, you know, the SHIF fund is supposed to collect more money. You have challenges with proxy means, and maybe you should have done an earmark tax instead of doing proxy. But sorry about that. But that is essentially the issue. The PHC fund, the ECCI fund, we need to focus there. The SHIF fund, we need to panel beat how contributions are being made. And also we need to improve the benefits package. As I said, we only improved surgeries by about 12% and not all of them. We have other very nice things like screening for cancer, you know, cervical cancer, prostate cancer. You know, these were extra additions. If you read the Gazette notice, the Gazette notice said they will be activated subject to availability of funds. So a lot of nice things that would make this reform ultimately work are subject to regulations not in place, operations not in place. And these are the things which we as Kenyans need to razor sharp, tease out and tell the government, focus here. The focus on SHIF is for large part in my thinking misplaced, because it's a carryover from NHIF. But the reform really is on PHC, ECCIF, and the extra benefits. And those are the places where we still need to tighten to make sure they work.
Thank you so much, Dr. Lishenga. As we come to the end of today's webinar, Florence has asked a question. So we'll go through her question and then Daktari will respond as he gives his final remarks. And then we will advise on the way forward. So Florence is saying, when it comes to registering for SHA, did you think about areas where there is no electricity, no Wi-Fi? How do you expect those old people to conduct themselves when it comes to registering? Dr. You might have spoken about it during your presentation when you're speaking about the operational component of SHIF. So you would just respond to that question as you give your closing remarks. Karibu.
So first of all, Winnie, thank you for having me here, and thank you everyone who's been patient for the last 2.5 hours. It's an honor for us in private sector for health to interact with you, and I hope that we do more of this, very illuminating, and certainly invite also you guys to our events and to our forums and learn from you. So thank you so much. So Florence, this is one of the areas where county governments really have a lot of responsibility. We have advised that the best place to register people is at the facility because you can do a lot more for them. You can do a lot more, gather data faster, and and this is usually the first point of access when people want to register. But we have issues, as you've mentioned, and counties need to think about solarization projects. They need to think about things like satellite internet. We have Starlink now, for instance, which is making it very possible to have very high-speed internet in very remote areas. So simple fixes, solarization for power backup. Can we use satellite-based internet? These are the kind of things that we need to invest in. But we have had a huge appetite for huge infrastructure projects instead of soft things like this that can make a big difference. But thank you, everyone, and thank you for listening in. And that is it from me.
So thank you so much, Dr. Lishanga, once again for making time to join this conversation and to just enlighten us on the transition from NHIF to SHIF, the challenges we're experiencing, and what the way forward looks like, and what we should actually be focusing on, even as we maintain our transition to SHIF. So on behalf of the Institute of Economic Affairs, my colleagues, I want to say a big thank you as well to everybody who's made time to join in and listen in and engage with us. Remember, the Institute of Economic Affairs is a membership organization. So if you are interested in joining us as a member, please reach out to us. And my colleagues in the communications team, Oscar and Michelle, will be very glad to walk you through what it entails to be a member at the IEA. And we also are still having these different conversations. So please be on the lookout on our social media pages and on our website for all our upcoming webinars. And if you feel there's an area that you would want us to engage in, please feel free to write to us and we will be more than glad to see what we can do about it. So once again, on behalf of everyone at the IEA, asanteni sana, and do enjoy the rest of your afternoon. Thank you so much.